Okay, so we are joined today by Dr. Rob Hegele. Rob Hegele is a distinguished professor of medicine and biochemistry at Western University in London, Ontario, Canada, where we are. He cares for more than 2,500 patients in his lipid clinic. His lab discovered the genes that cause more than 20 human diseases. He was among the first in the world to use 5 medications that are now routinely prescribed to treat dyslipidemia or diabetes. He's published more than 870 papers, and I'm sure the number's even higher since writing this, and is in the top 1% of highly cited scientists in the world. The website expertscape.com in 2022 ranked him number 1 globally in the area of hypertriglyceridemia, number 2 for disorders of lipid metabolism, and number 3 for hypercholesterolemia. He received the 2019 American Heart Association Lehman Duff Award and the 2020 FH Foundation Pioneer Award. He has co-authored many clinical practice guidelines for cholesterol, blood pressure, and diabetes. He has trained numerous physicians, medical students, and graduate students, and I include myself in that group. So I thought it was really important to read this bio just to kind of showcase how fortunate we are to be able to pick the brain of such a world expert. And I was actually just looking at your Google Scholar page, and you've only been cited 6,453 times this year. So is this a slow year for you?
Yeah, well, the year's not over yet, Andrew.
I think it's also worth mentioning that when Andrew was going over my bio with Dr. Hegele, he said, "This is Tommy Caldwell. He owns a gym," which is accurate.
It's accurate and sufficient,
and saves on time.
Yeah, definitely.
Very good. So Rob, I was just thinking maybe we can start. Can you describe what is atherosclerosis? How does cholesterol play a role, and why should everybody care about that?
Right. So the reason that everybody should care is in Canada, in terms of the causes of death and causes of premature death or preventable death. It's about 40%. So about 4 out of 10. And it is due to this process of atherosclerosis, which is a process that goes on inside our arteries, inside the plumbing system of the body. So if you imagine, you imagine your body, and then you strip away the skin, strip away the muscles, strip away the skeleton and organs, and what you're left with are blood vessels, like a intricate map of the underlying blood vessels, which perfectly matches your shape. It would be as distinctive for your shape. I mean, distinctive for you. And that's your plumbing system. That's what keeps the blood flowing, from the heart to all of the distal cells and tissues. And it keeps, energy, oxygen, sugar, nutrients going. That basically, and it's going 24/7, and that's what keeps us running. And so, it's like, the plumbing of your home then. So the main thing is we want to keep the plumbing clear so that all of these functions that go on without you even feeling it or knowing it are happening without interruption. Now, the problem of atherosclerosis happens is when we start getting blockages in the pipes, if you want to think of it, continuing with the plumbing analogy. So these little arteries, they're very, very fine, fine blood vessels. Some of them are fairly wide caliber, starting with the aorta that comes right off the heart, but then they branch out, and then as they go further from the heart, branching into smaller branches. So the problem is along the interior of those arteries, onto the interior of those pipes, with time, there can be repeated injuries that are going on that we don't even feel. We don't even know that that's happening. And then the injury happens to the lining. It heals over, but it doesn't quite heal over quite perfectly. There's a little bit of a bump there in the kind of the inner Teflon layer that's coating the artery, and then that that is prone to that little imperfection is prone in the future to another future injury, and then it becomes sort of a doom loop, vicious cycle, and then eventually you can start impinging or narrowing into the lumen, into the interior of the artery. And the reason that we care about cholesterol is that in these early stages, when these narrowings of the artery start to happen, that it's actually cholesterol that is initiates it. Other things can do it. Toxins from cigarette smoke and certain kind of viruses can do it, and high blood pressure can cause shear stress. All of these things can cause injuries to the arteries, but then cholesterol in particular gets stuck. Like once the artery is exposed, cholesterol gets in there, and then like I said, gets stuck there, embedded, and then the artery doesn't quite heal over perfectly, and then it sets up a vicious cycle, and then it happens again and again. Eventually, with time, with decades, it can block off the artery. And the rate at which that happens depends on how high the cholesterol level in the blood is.
And that's a direct association.
Right. And it's been pretty much established now. So the question has always been, like there's like the forms of cholesterol, the so-called good cholesterol and bad cholesterol, LDL and HDL. And the question is are these just sort of kind of innocent bystanders? Are they markers for something else that's happening, or are they directly involved in the disease process? So can we actually say that they're the smoking gun, like the bad cholesterol, the LDL? Is it the smoking gun? And I mean, the evidence is overwhelming that for sure it is directly injurious. It's not just a marker for something else that's going on. It is, in fact, the direct player to the disease process. In contrast to other kinds of risk factors, which are just correlated but not directly causative.
So that is to say, if in somebody who had normal blood pressure, normal sugars, no inflammation, no other chronic diseases, if they just had elevated cholesterol levels, that would be sufficient to cause the disease.
Yeah, absolutely. So I had a 3-year-old child. So, I mean, so this just is a total example. Now, fortunately, it's a super rare condition, but this was a child who had a genetic deficiency, totally unable to clear bad cholesterol, like a liver problem within the liver, and born with that, inherited 2 copies of the gene, one from each parent, and had crazy high levels of LDL cholesterol, like off the map, like 20, like with a normal level being 2 or 2.5. And this child suffered a fatal heart attack at the age of 3 and died. And that was like a huge, loss for the family and for the parents, obviously. I mean, it was devastating. So that's the youngest that I know. And nothing else, like no smoking, no diabetes, diet, so that was the pure problem there was just too much cholesterol. Yeah. So that's an extreme case, but the extreme case that's informative. Now for the rest of us, it's just some sort of fortunately milder version of that. And in his case, it was genetic, so that short of gene therapy or some like heroic kind of treatment, there was not much that could be done. But fortunately for the rest of us, who then may have just a slight increase in cholesterol level, there's actually a lot that we can do, that we can take upon ourselves, action-wise, volitionally, to bend the curve, to turn the corner on it.
And is it fair to say that, atherosclerosis itself, not necessarily to the degree that it causes a heart attack or some other bad outcome like that, but the buildup of some cholesterol in the walls of your blood vessels is inevitable for everybody?
Yes, for sure. And we even know, and this even first became apparent in the 1970s. So when they did autopsies on soldiers that came back from the Vietnam War. And these were like 21-year-olds. And this was, studies in the US, and they did autopsies. They already found that there were like cholesterol lesions there in these 20-year-olds. Now, they'd lived in a North American environment in the 1970s. Now there was also the stress of wartime as well, but we pretty much know that these precursor lesions, these early fatty cholesterol deposits in the arteries, and especially in our society, they are ubiquitous and they start at a young age. And then if you then look at people in their 80s or 90s, it is pretty much ubiquitous. And by that time, the arteries, not only are they, not only is there like cholesterol, which is a soft, squishy, kind of oily substance. If I was to give you a lump of cholesterol to hold, or to feel in your hands, you'd say, man, this feels just like candle wax to me. This is like that's what it is. I mean, that's the chemical nature of cholesterol. So we need a little bit of it, and then it gets, some of it then gets stuck in the arteries. Eventually it hardens over, it gets calcified, and then that's, you hear about like hardening of the arteries, or calcific arteriosclerosis, but it's all part of a continuum. And just as you said, Andrew, super, super common. We see it in, we pretty much everybody by the age of 80 or 90, has that. The only issue is it severe enough to be causing a blockage, or is it just kind of on the side, just kind of coating the side of the vessel and just allowing blood to continue to flow through, but not fully causing a blockage?
So do you have any thoughts on why evolution would design us this way? I know, so Tommy's heard me go off on how there's no intent in biology, but clearly cholesterol is necessary for life. It's in all of our cell membranes. It's a necessary precursor for steroid hormones, amongst other things.
Yeah.
So why would you create a system that is also potentially going to kill you?
Right, for sure. Well, so the overall rationale is that back in the day when our kind of evolutionary ancestors were like emerging from the primeval slime and coming out of the oceans, right? So then the problem was that we needed, like when we're on the terrestrial world and walking around, but we still need some way of like transport. Like, so in the ocean, the nutrients are all around, all around us and so on. So the first fix then was to bring the ocean inside us, to the ocean inside our veins, right? And so that's like saline, that's like plasma, salt water. So that was then the evolutionary step forward that allowed us to be terrestrial, is that we have the circulatory system, which is essentially salt water, if you separate the cellular component, and that's what then transports all the nutrients inside us. It's the ocean inside our veins. But then, and so you get things like, okay, well, what's essential? Salt. Well, okay, salt, obviously, can be dissolve in water. Sugar, proteins, amino acids, that's all soluble in water. But then you run into a problem when you get to the fatty nutrients. So fats, triglyceride, cholesterol. So everybody knows that oil and water don't mix, right? So that's a problem. So we have this water-based, saline-based transport system, and yet, things like the brain, like everything you mentioned, the brain, steroid hormones, okay, that's all lipid-based metabolism. So the hack was, or the solution was, to create these little particles, which are called lipoproteins. So if we look at it under the microscope, they've got, and I kind of like, when I explain it to patients, I say they're kind of like little mini spherical M&Ms or Smarties, if you look at them. So in the core, they've got the cholesterol. The chocolatey center is the lipid core. It's the lipid that it's got to be delivered to wherever it's going, to the brain or to the, to the heart, and then the candy coating on the outside, that's the protein, the ApoB protein in the case of LDL. And so the protein is actually dissolves in water. And so that by coating the fat with the protein, so it's a lipoprotein. So when you hear these terms like LDL, low density lipoprotein, so the L is for lipoprotein. So that's what that refers to. It's these little tiny particles where it's the cholesterol that's in the core, and it's camouflaged. It goes through the blood without precipitating, without because it's coated by the protein. So the body thinks that it's like water soluble, and therefore the fat can get from the intestine or from the liver, and it can go through the plumbing, through the saline, and get to wherever it's going, get offloaded at the surface of the cell, and the remnant particle comes back, and the liver gets rid of it. It's a really elegant system. So so the thing is with anything, then if you're thinking about, okay, but you can get too much of a good thing, right? So with these cholesterol particles, with this LDL particles, the body does not need a huge amount for its activities of daily living. It does not need a huge amount to synthesize steroid hormones, or it doesn't need like a huge amount for cell membranes. We don't want too little either. It's like Goldilocks, we don't want too little and we don't want too much. We want just the right amount. But the problem is in our society, with just living in a sea of like caloric excess, that just with time, just by being a citizen of North America, we are taking in more fat, more of the substrate that the liver can use to build these little particles than we possibly need. So we like a baby. So just to put it into context, the doctors use kind of like an LDL number of 2, or 1.8. That's considered to be a good number, or even lower is considered to be good. So babies have a level of 1. When they're forming, everything's fine. their brains are growing, they've got no issues. But by the time you're an average 25 30 year old 35-year-old in North America, your levels are 3.5, and it's statistical. The more you have of these particles, then with higher levels, the more chance that they start to get stuck on the inside of the arteries, and that these injuries to the arteries are happening all the time. And so it becomes a stochastic, like a statistical thing. And then there are people that even have a genetic issue, like that child that I described was the extreme case, but there's people that have a milder form of that, which are like the kind of the basis of my practice, where their LDL level is sort of 6 genetically because they can't clear it. And if we don't do anything for them, they start getting like heart disease and strokes in their 30s and 40s. And then so that's a genetic issue. But then most people fortunately have a milder version where it's a diet related, maybe just a small genetic influence. But that's really what we're trying to combat. And for most people, it actually can be the excess of these LDL particles can be overcome to some degree with diet. We can do some with diet, but then of course, once you have a heart attack or a stroke, it's a different story. Then the meter's running, and we have to get more serious.
Yeah. So since you mentioned the dietary part, like can we really blame a lot of the problem in North America on just the caloric excess? Because I mean, people might be surprised to find out that of the cholesterol circulating in your bloodstream, only about 15 to 20% of that
Correct.
comes from a dietary source.
Yes.
So, is that 20%, is that the true ceiling, or can you bump that up even more if your diet is horrendous?
It's a great question, Andrew. So it follows like everything. Like everything in medicine or biology, it follows a bell curve. So some people will get like like we put them on a vegan, suddenly take out the trans fats, take out the dietary cholesterol, like cut back on their glycemic index, and then all of a sudden they can get like just with the diet, they can get a 35% reduction in their LDL, but they're on the tippy top of that bell curve. Then if we go to the middle of the bell curve, it's like 15%, as you said, 15-20% if we're fortunate. And then we have the opposite, where there's people that then they go to the wall and they do everything with their diet and they lose weight, and it has zero impact. It's I mean, unfortunately, they're a minority. So we kind of say that, the two extremes, the people who are like really super responsive to diet, or the people who are super resistant to diet and lifestyle, maybe 5 or 10% for each extreme. Fortunately, for the 80 to 90% of us, we are then somewhat responsive, but it's not a 50% reduction. It's like a 20% reduction. But then at least that helps. And that 20% shifts the whole curve. That shifts the whole population curve. I mean, if we could get everybody just to reduce their LDL by that 15 or 20% in North America, that already would have a huge impact on a public health basis for heart disease and stroke reduction.
Okay, so I want to get into a little more specifics about the diet and then when we should start thinking about screening people. But I don't, Tommy, do you have any questions you wanted to throw in at this point?
Yeah, there was a few things I wanted to go over. Starting with, we've talked about how cholesterol, the ability to control high cholesterol through diet is limited.
Yeah.
And you also talked about the injury to the circulatory system is part of the equation of disease or severity of disease or onset of disease as well.
Yeah.
So my question is, if you could only pick one of two things, and we're assuming this is just an average quote unquote healthy population, not anyone who has a specific genetic condition.
Right.
If you could only pick, we can bring down your slightly high LDL, or we can prevent any of this injury to the circulatory system. Which one of those two factors is going to be more critical to preventing long-term disease outcome?
It's a great question, Tommy. So I think it would only be speculative, because we don't have any sort of intervention or any treatment, at least to my knowledge, that would do the second, that would like globally do some kind of global protection that would protect the sort of the endothelium, the Teflon coating of the blood vessels from injury. We would love to have that, but so if there was some way of like just like doing it's like, like the protection for your car, when you do like the rust proofing, that would like kind of injury proof your vessels, we would love to do that. But the issue is that there's many ways that these injuries can happen. So that can happen from physical forces, can happen from shear stress, can happen from inflammation, can happen even from viruses. There's sort of, or chlamydia. There's different kinds of infections, and cigarette toxins, air pollution. So there's many ways that can incite. So, but yeah, if we had some kind of magic bullet that would institute that kind of protection from injury, obviously that's the first step, that's the primordial step. But that's right now so far just utopian ideal. So but for example, if we tell people to quit smoking, that already eliminates one way of injuring the blood vessels. Or if we tell people to lose weight, that reduces their systemic inflammation, that's another way of, but they're different ways, different mechanisms of injury. But then the second part, though, is the final common pathway, that once the injury happens, then what actually physically gets into the arterial wall and starts to build up is the cholesterol. So that is actually so again, like no matter what started the injury, the thing that propagates it is the cholesterol. So one way then to at least stop that or nip that in the bud is to get the cholesterol down, so that at least while these injuries are going on, you're not then loading up the artery with the cholesterol that's unnecessarily high.
Yeah, that makes sense. And I also wanted to ask, how far back do we have reliable data relating to cardiovascular disease? And the reason why I ask that is, while human beings have for a long time been smoking, drinking, engaged in violence, all of these things are going to play a factor in their health. if you go back far enough, you can remove some of the modern dietary issues. So how far back does the reliable data go? And does that tell you anything about the modern dietary lifestyle and its connection to disease?
That's an awesome question. So yeah, so I think the reliable data, because we didn't really understand atherosclerosis, like that actual pathologic process of what was going on. It was only about 120 years ago. So Virchow and Anichkovsky and these like very famous scientists that actually figured out what's going on in terms of the actual injury to the plumbing. And so from then we could then make the correlation. But then going back further, it was these sort of vague descriptions of, angina, chest discomfort, and like, but we assume, so we assume it's always been around, but it is certainly a disease of affluence, and it's a disease that is related to stress as well. So I'll give you one example. So I did part of my training in Salt Lake City, Utah. And so and that was amazing. That was like many years ago. That was like when I was still training to I just finished my clinical endocrinology and doing some extra research. And the reason I was in Utah was because the LDS church, the Mormons, settled there, and they have incredible genealogical records going back, and they keep the genealogy essentially for religious reasons. It's very important for their faith to go back. So they go back and they know their own history going back. And in fact, even parenthetically, and now a lot of these companies like Ancestry.com and so on, they actually have come from the original kind of research that was done as building the genealogies that were done by LDS researchers or Mormon researchers, except now they've added, DNA technology on top of that, and allows these really interesting things that the public can buy even and look into their own ancestry. So anyway, I was working there, but we had this one family that had this genetic issue with high cholesterol, high LDL cholesterol. The condition is called familial hypercholesterolemia. It's a condition that affects about one person in 250 in Canada and in the US. And so we were looking at the descendants that were living at that time, and the individuals that carried this gene, so we did genotyping, we found the variant, we found the gene, they were all starting to get heart disease, the males starting to get heart disease, even though they were like fairly good shape and so on, in their 30s. And some were even like dying in their 30s, but but at least developing angina, then needing to go for bypass and stents, and like by their 50s, they pretty much, everybody had it. But then we went back genealogically. So this is now getting to the answer of your question, because we had death records of earlier generations, right? And we were able to go back about 10 generations, and we were able to deduce, okay, who must have, because it was the same. We had the DNA testing. So we didn't, obviously we couldn't do DNA testing on the deceased people, but we could deduce who was a carrier of the gene just based on the position in the family tree and how it got passed down. And what we were finding is there were people who were carrying the gene, who must have been the source of the gene, the genetic variant, and they were living into their 80s and 90s. And this was 100 years ago, 150 years ago, right? So like, what's up with that? How did that happen? It's the same variant. Today, people are dying in their 30s and 40s, and yet with the same genetic variant 100 years ago, they were living into their 80s. So we think then it's the interplay with the environment that we're exposed to in North America. That was we ruled out other things. Okay, maybe another gene came in that was even making it worse, or maybe there was something else, but we sort of ruled all of that out. And what we came down to was the fact that there was like no McDonald's 100 years ago. Even like the way people ate, if we read like the historical records, they'd like have a cow, or they'd have, but they wouldn't like slaughter a cow to have like burgers. It would be like meat was like a very very infrequent kind of thing. And then of course, everybody was physically active and doing their 20,000 steps back in the lifestyle, 100 years ago. And now, today, it's just like so then you superimpose today's lifestyle on top of the genetic susceptibility. So then the good news, though, that we could then translate back to the family is that we could say, okay, well, look, your ancestor lived to be 80 years old despite the fact that they had this genetic tendency, and there was like no statins in those days. So, here's maybe a good lesson from your own family tree that maybe if you go back, as much as you can, introduce a little bit of more physical activity, cut back on the processed foods, maybe do some meditation, cut back on your stress level, that maybe in addition to our medical treatments, but maybe that can help you. So anyway, a long answer to your question, but that was actually a really great question.
Do you have any do you have similar tools with existing cultures or tribes or parts of the world that you can look to for those same sorts of reasons? Like, is there any existing populations in the world where their particular lifestyle is so preserved from modern exposure that we're looking at those populations to get the same kind of answers?
Yeah, so I think there are, and so this is then going into this kind of work of sort of genetic epidemiology, and that's a very, very active area. So these are also traditionally understudied populations. So that's like, for whatever reasons, like the research funds in the past have not been. So we have a lot to learn, and even a lot to learn from what they know, from their knowledge, and even like indigenous populations in Canada. We have a lot to learn from them, and fortunately, there is now more research that is being done. But yeah, and it does seem to be, at least from the kind of anecdotally, it does seem to be the same kind of thing, that in the past times there was at least less documentation of things like diabetes and heart disease, whereas today, because of course, the very common lifestyle in North America, for instance, or even around the world, the coca colonization of the world, that these illnesses, these conditions are becoming more prevalent. So I think the general answer to your question is yes, there are certainly specific examples, and it's a super active area for the research community.
Okay, you can continue, Andrew.
I'm just itching over here. So when should people start getting screened? Because the guidelines don't agree. So
Yeah.
in the American guidelines, it says that 20,
Yeah.
anybody over age 20 should have their lipids checked.
Right.
In Canada, it's 40. So that's
Right.
a 2-decade gap, unless you happen to have some other diagnosis, like
Right.
obesity or diabetes or something
Yeah.
else. So, where do you fall in there?
Yeah. Well, so for me, because I'm dealing with a very specific clientele. So my patients are referred to me with genetic issues, and of course we have been able to genotype all of them. So this is like one advantage of working, like I have both a research lab, and so when I first see a patient, we do, in addition to lipid profiling and advanced lipid profiling, an ApoB and LP little a, and then but we also do DNA testing. And I've done that for the last like 25 years. So for me, like the DNA test is almost an extended part of the physical exam. So it's like, and so I feel like I need to know that about my patient to fully understand them. Um, but that's a different population. So there, the earlier the better. If you're dealing with like any kind of genetic predisposition, the meter is running on the trajectory curve for disease.
And I guess so how would somebody know if they might
So
have a genetic problem in their family that needs to be looked into?
So the first thing is family history, and what is commonly quoted is like a male first degree relative under the age of 55 who has had some manifestation of heart disease or stroke. Female, they vary. It's some say 60, some say 65, but that's the first clue that at least you should get your cholesterol checked with the thought that this could be, a genetic component to the cholesterol problem. There are like these very subtle physical findings that we can see on physical exam, but honestly, those are rare. The patient may not even notice it. Like, person may not even notice that they have it. But these are things like cholesterol ring around the eyes, or cholesterol deposits in the eyelids, or bumps in their extensor tendons. But honestly, even like physicians miss those, so it's patient would not be faulted for for missing those kinds of physical features.
So primarily it's the family history. So if you're
Yes.
if you're a 20-year-old and your 50-year-old father has a
Yes.
heart attack,
Yeah.
then you should be going to get your blood
Yeah.
work done.
Your blood work done. And so the good news is, if it's normal, because we know that, I mean, so that the heritability of high cholesterol, it comes from both parents. I mean, it can be a single gene coming primarily from one parent, but we know also it can also be polygenic, where you're getting like small genetic contributions coming from both sides. And so in that case, the high genes, like the genes that are causing the high cholesterol in dad, they may be neutralized or somewhat counterbalanced or offset by genes from mom, so that then your personal cholesterol may actually be okay as a 20-year-old. You may come back and your LDL is 2.5, and then you don't need to check it again for another 5 years. So it does provide reassurance. However, if the LDL, then you do that because of your dad's history, and your LDL comes back at 4 or 4.5, well, that's above average. So it's not to say you need to start medication right away, but you need to start doing something, because it's a chronic disease, and it's working away all the time. The LDL is having an impact on your arteries 24/7. And so then you need to fight back, or do something to counteract it. Initially, we recommend lifestyle and diet. For some people, it's so high that we go to drug treatment if that doesn't work. But that's so in my so the guidelines for the general population of Canada say 40. I think that's a little conservative. I think probably 30. I think the Americans, they're screen everybody who's 20. In the future, that may turn out to be correct. We don't actually have a study, like a peer-reviewed, like randomized trial, that shows that that's correct. My intuition tells me that that's probably correct, but for 40 we do. But
well, that's good to know, because
Yeah.
I assume that where the American guidelines are coming from is sort of a throwing up of the hands and going, our
Yes.
population is just so sick
Yes, correct.
that we may as well check them at 20, because then we're going to have more time to do something about it.
Yes, I would say that's quite fair, Andrew. Yeah.
Okay, so on the basis of that, so one of the issues that I have in my practice, because the guidelines go on to say, so you check your lipids, but then to determine whether or not you do something about it, i.e. medications, you have to plug somebody into a risk calculator, which spits out their risk of having a heart attack or stroke within the next 10 years.
Right. Yeah.
But if you have somebody in their 20s or 30s, that's going to be low, sort of regardless of the other numbers that you put in there.
Correct.
So, and that's even if they are overweight and have metabolic syndrome and other things going on, which clearly makes them higher risk.
Yeah.
So how should we be thinking about making adjustments for that?
Mm-hmm.
And, that would potentially lead us to having somebody qualify for medications at an earlier stage.
Right. So there's this. That's a fantastic question. So the first answer, the overarching answer, is that there's right now in the, as we speak, people are working on these longer term risk calculators that are going to be 20-year risk, 30-year risk, starting at 25, starting at 20. So those are going to be available. They're just not ready for prime time yet. But I'm going to predict that certainly within the next 3 years, we're probably going to have some new, like, ultra long version of Framingham or some replacement of the risk calculator that is going to be a reliable, peer-reviewed, like, long-term risk calculator. So that's going to go a long way to solving the problem. But then what do we do in the meantime? What do we do until that's available? So then, this is, I mean, unfortunately in medicine, we deal with uncertainty all the time. So what do we do in medicine when we don't have a, clinical trial to tell us what to do? Well, then we don't have gold level evidence, but then we use like bronze level evidence. Okay, then we take, then check the patients, and things that the guidelines recommend, these other blood tests you can do, C-reactive protein, LP little a. You can also do an imaging study. You can do like a carotid Doppler, like a coronary calcium score in somebody in their 20s. That's a little premature. That's going to be, that's, even if the person is highly at risk, it's still going to be 0. So you would be reserving those for people who are older, where we're like concerned about their risk. But there still are there are these additional tests that you can do that maybe might give you an additional piece of evidence that might point you in the right way. Another thing is these again, not ready for prime time, but are these DNA tests for coronary heart disease risk. And these are the so-called mega polygenic scores for heart attack, or mega polygenic scores for global cardiovascular disease. And then these kind of now we can look at the whole genome, and we can add up all the effects of all the different pathways and then come up with an integrated number. And then it puts you then on the bell curve of genetic risk. It says, okay, well, you look great on the outside and your cholesterol numbers and everything are fine. But then when we look at your genetic risk, you're at the 99th percentile. So you're like in the top 1% for genetic risk. So even though you're feeling great and you look great, but genetically you're prone to get it. And then, okay, so if you have to then like bite the bullet or push harder for someone, then that type of information would be useful. Now, those are not quite ready for prime time use yet, these polygenic scores, but they are getting better. And what they need to have is some kind of global summit where all the gurus that are working on this will sit together and come to a consensus as to like what's the best way to order this. Because right now there's like 30 different scores. Oxford has their score and Harvard has their score, and then there's no sort of unified consensus on how best to use these. But I think one day that might be another piece of evidence that you could use. But but for now, those things that I mentioned, LP little a, CRP, yeah.
And in terms of what people should ask for, so I often on this platform, I sort of encourage people, like, you need to seek out things, because primary care providers are overwhelmed. They're not reaching out to you and saying, hey, it's time to come in for your screening. So people need to take responsibility and go in and request these things.
Yes.
And we're still not. So I love the fact that ApoB is in the most recent guidelines. I still think we're in that 3 to 5 year acceptance period where it's going to become common practice.
Right.
But do you think it's fair that if somebody walked into their family doctor's office and said, hey, like, I want to get screened, I want a lipid panel, and I'd like an ApoB included as well, like, is that a reasonable thing for them to do?
I think very, very much so, for sure. And so ApoB, so going back to my analogy, so of the mini M&M or the mini Smartie, so that that's the particle is the LDL, so that's like the little particle, the little that gets stuck in the wall of the artery. So there's two ways to skin a cat. You can either measure the chocolate, you can measure the LDL cholesterol, or you can measure the candy coating. That's the ApoB. So technically you would think, well, both of them are telling you the same thing, because there's both, it's just telling you. But there's a subtlety here that you actually can get more information by adding the ApoB. And so, and it's especially then our patients who watch a lot of American TV. They hear, or they go on the internet, or they read about these small dense LDL particles. They say, "Oh yeah, I was watching, and Dr. Oz." This was like before Dr. Oz,
Before he lost his governor's race. Yeah.
but when he had his TV show. But Dr. Oz would say, "Oh well, if your doctor might measure your cholesterol level, but if your doctor is not measuring the size of the particle, if it's not measuring the small dense LDL, then your doctor is not practicing it." So as it turns out, just like a stopped clock is right, twice every 24 hours. So like Dr. Oz happened to be correct on that point. And what it is that here, so that you've imagine this situation. So you've got two scenarios. You've got a patient, and I'm going to use the example of the M&M. So you've got a patient, and they've got like one big M&M particle, and so then the amount of chocolate that's inside the particle, let's say it comes to a total of 2, and then but this got 1 ApoB, so the ApoB on the outside is 1. Okay. Now imagine another patient, they've got 2 of these smaller particles that Dr. Oz is worried about, right? So the total amount of chocolate inside those 2 smaller particles, that adds up to 2, right? So the LDL level is the same as the first case, but it's divided amongst 2 particles, that when you then do the ApoB is 2, right? It's because there's two molecules of ApoB. So that's actually telling you that patient has smaller particles. And these smaller particles, we know physically, are more prone to penetrate into the wall of the artery. The bigger particle is actually kind of, sometimes bounces off. It's not as so the ApoB in that situation. So I think that's very reasonable. And I think it's very reasonable to order both, actually, to have an LDL cholesterol and an ApoB. And then and if the ApoB is out of scale or out of scope compared to the LDL, that's telling you that there's a lot of these smaller, denser particles. So that patient is even at higher risk than what their cholesterol may be telling you.
Yeah, that's great. And I think just part of the concern at this point with on the provider side is just if you haven't done the CME and you know how to interpret it, then you never want to order a test that you get back and go, I don't actually know what this means.
Correct.
But so we'll get there.
Yes. Yeah. No, but I agree. So it's a 3 to 5 year, but it was the same thing with LDL. So I'm old enough to remember, that people were just looking at total cholesterol, and it took a while to, get now, and now everybody's focused on LDL, and now trying to get them off LDL and thinking about ApoB. So you're right. There's education on the provider side for sure.
Okay. So if somebody's been told now that they have elevated cholesterol,
yes,
what do they need to do to their diet?
Yes. So the main things in the diet, the main components of the diet. So another thing is that we know that the response to diet differs between people. So there is no such thing as one size fits all for the diet when it comes to cholesterol.
So not just keto.
So keto, and in fact, we published this, that there are some people on keto where that shoots their cholesterol up. Their cholesterol goes up to 10, and they develop like cholesterol deposits on their skin. And so but they feel good, they've lost weight and so on, but their genetics is such that, so most people with that, like average genetics, you can then do the changes that are involved in the keto, and that, that'll have beneficial effects on weight and so on. But yeah, definitely there are people who have an adverse response. Their cholesterol goes up, and then colleagues from Ottawa noticed the same thing and published patients like that as well.
Does that include the ApoB going up? Because
yes.
I think there's this notion of the lean mass hyper responder where maybe your total cholesterol goes up, but ApoB particles don't, and so that's not actually a more pro-atherogenic situation.
Yeah, but no, but but there are no in these cases. Now there are case reports. There's like 5 of them in our study, but it was ApoB,
okay,
and it was atherogenic lipoproteins. So I would say in general, like for an average person, if you're just guessing, and the things we don't know how to test, there's not a genetic test that can tell, oh yeah, this person is going to respond poorly to a keto diet. So you're just kind of playing the odds there. So the odds are generally speaking, the keto diet is going to be safe and effective. But just bear in mind that, like, again, one size doesn't fit all when it comes to diet. And then there are some people that will do the opposite of what you think on a keto diet.
Yeah. Sorry, I didn't mean
And
to derail you on that, but yeah.
yeah, yeah, no, but
Just because I mean, and I define just practically speaking that
yeah,
ketos, it's very difficult for people to follow much of the time, and it's
right.
generally not all that sustainable. But of
Yeah.
course, there's a lot of diet evangelism behind it.
Right. So I think we need to be careful. And then I think, so I think in general, I mean, it is, just general principles. So caloric restriction, trans fats and saturated fats for a person with average metabolism. So the liver then takes that and then, builds cholesterol out of it. So there's cholesterol in animal, like any sort of animal product. There is cholesterol there, so you can like reduce your total consumption of animal-based proteins, and that's going to reduce the amount of like preformed cholesterol that you're taking in. But then the liver is also pretty smart that you don't have to give it preformed cholesterol. You can give it like trans fats and saturated fats, and then it can make the cholesterol containing lipoproteins out of those. So it's like all of those measures. um Glycemic index is super important, but that's more on the triglyceride side. So we didn't talk at all or very much at all about triglycerides. Triglycerides are a related lipid. It's less famous than cholesterol. So if I said that like cholesterol is like candle wax, triglyceride is like thick, rich Devon cream. It would be like whipped cream. If I gave you like a vat of triglycerides to look at, it would look like this cream. And we need a little bit of it. We need like a level of 1 to 2, but then some people have a like level of 5 or 10. And there, the liver takes simple sugars. It takes, your high glycemic index foods, and it actually makes triglycerides out of sugars. So the glycemic index is more important for the triglyceride. And then triglycerides themselves, we think probably, or there's a component of them, there's the remnant component that's probably bad for the arteries. It's not as a direct story as it is for cholesterol. But so it depends on the nature of your problem. Triglycerides are related to obesity. They're related to diabetes. Triglycerides are much more like diet related. Also alcohol. If you're like drinking more than one drink a day, that's going to raise your triglyceride levels. So
And it's part of the criteria for metabolic syndrome is an elevated triglyceride level.
yes,
Now, just from one quick sort of mechanistic question. So we know that in insulin resistance, one
yes.
of the pathogenic components is you have a buildup of fat or diacylglycerol inside the cells.
Right.
Is that mainly driven by excess consumption of sugar?
Yeah, I would say correct. I would say it's sugar, but it is actually both, but mainly it is sugar. And then it's the sugar that then is triggering it's mainly carbohydrate metabolism that is triggering the hyperinsulinemia. But then if there's fat around, then that just gets thrown into the mix. That's just like extra toxicity. That's just extra. But the prime mover, I think, is sugar.
So do you then promote mostly like a plant-based
Yes.
dietary pattern, or are you okay with lean meat, low-fat dairy? Like where do you
Yep.
fall there?
Yep. So yeah, small. So so like the portion size is also, So I tell my patients, definitely don't go for thirds, and a lot of them like laugh in recognition, so they know what I mean. So they're like, a lot of them are going for third portions. So even just to get them to go to a second portion, that's already a step forward. So yeah, but even like so the dietitians say like a piece of lean meat the size of a deck of cards. So that's the sort of size in terms of that would be considered a portion size. Yeah. So and then yeah, low fat dairy, and then yeah, plant based as much as possible. Yeah,
And
plant
do you
based.
think the data around red meat is, is that is that real? Like let's say you've got a good quality source of red meat, like a proper, pasture raised cow,
Right.
versus the McDonald's version of red meat, which is a
Yeah.
processed patty.
Patty, right. Yeah. So I agree with you for sure. So I think that there, but again, then it boils down to portion size as well. So you can, and then there's like marbled red meat, which is, or your marbled meat, which is like some people then consider more of a, more of a delicacy or whatever. But yeah, but the first situation that you've described, where it's leaner cuts of red meat that are of smaller size with or like more constrained size, say um, compared with say the McDonald's version of beef, for sure that would be preferred. But like everything within moderation, right? Everything within limits.
Yeah, I just always get a bit leery when sort of red meat just kind of gets castigated to just don't eat it. It's terrible
Yeah,
for you and it'll give you cancer and all this stuff. And it's like,
yeah.
well, there's not really good data for that.
I agree with you.
There's a few things that I want to dig into here a little bit higher level on the dietary side, because I find a lot of times the issues with podcasts like these is if someone's going to listen to this,
Yes.
they're already biased to be a healthy individual. Either they are healthy, or they're interested enough in being healthy that they're probably taking a lot of steps moving into the right direction.
Yeah.
But then when you talk to people, whether it's it's you or it's Andrew, who are so used to working with a diseased population, a lot of times you get used to making recommendations that you can't necessarily extrapolate out to a fit, healthy person. So when it comes to those sorts of dietary recommendations, I just want to ask a couple of black and white questions just for the sake of clarifying a few things. If you could only cut one of these two basic nutrients out of someone's diet, saturated fat or processed sugar, and I know this is not there's a lot of nuance that's required with questions like these, but if you could just pick with someone who is at risk but otherwise healthy, and they can either remove saturated fat or they can remove processed sugar, is it easy for you to pick one of those two?
Well, I would really be interested in what Andrew thinks. So I would say, so in sequence, I would say, I mean, obviously I would, would say both if possible, but if I had to force to pick one, I would say I would start with sugar, and then I would also simultaneously try to cut the saturated fat as well. But I would be super interested in Andrew's opinion.
I agree. I would go hard on the sugar first. Start with smoking. That would be
Yes,
the
yeah.
apex predator.
Yes,
But
right.
then not far below that is sugar, especially the sugar sweetened beverages. And I've got no end of examples in my own practice where literally just eliminating drinking soft drinks has led to like a cutting in half of somebody's triglyceride levels and a reduction of 5 to 10 kilograms in weight. Like it's really unbelievable.
And then I have another similar question, which again, the person I'm describing here is a unicorn in the modern world, but these people do exist and they do listen. So I want to make sure that they feel like their lifestyle is represented in these conversations as well, because even healthy people are going to be at risk and they're going to be interested in disease prevention, probably more so than people who are more likely to get the disease. So if somebody has a high cholesterol level, again, otherwise healthy but at risk, so they have high cholesterol where it's not on the extreme end, but it's something that you're concerned about the direction it's going, but they have low ApoB, triglycerides, insulin, HbA1c, all of these other metabolic disease markers are not just moderate but in a healthy range. What level of concern do you have for that person when really the only thing that's standing out is the higher cholesterol level? And what sort of actions do you suggest, or what path do you take with that person?
So again, I would love Andrew's opinion. I'm going to weigh in first. So often in that situation where the total cholesterol is high and then everything else is good, and your ApoB, that what we actually see is that there's a high level of HDL. So we haven't talked about that very much, the high density lipoprotein, or the so-called good cholesterol or protective cholesterol. And we see that like typically, for example, in young, fit, women. So women in their 20s, so they may have like a total cholesterol of like 6.5, and the family doctor is worried. But then you look at the HDL and it's like at a level of 1.8. So in general, the HDL kind of functions a little bit like a vacuum cleaner. So it removes cholesterol from the So where the LDL is like depositing cholesterol into the arterial wall, the HDL is working to leach it out, or to take it back. So that could. So I think there often if the only problem is a high cholesterol, and then you do the fraction, it could be from high HDL, then you could even feel like more confident, and then just no specific recommendations. The one interesting thing about HDL is that now with these huge population studies where they're now studying like, million people in England and, 500,000 people in Scandinavia, they're finding these rare, like, people with super high HDL, like HDL that, you can't imagine, like we rarely would have seen it before. And it seems that those people, which is, again, very, very rare, but those people don't seem to be protected. So it's, and in fact, they see there's something wrong with how their HDL is working. So again, it's going totally off on a tangent, I think the short answer to your question is, if the only issue is a high cholesterol and everything else is good and the family history is good, then I would not freak out about it. It's just, something that, you need to, you need to manage and you need to monitor, but you don't need to. Anyway, sorry, I went on too long.
Yeah, that HDL example, I mean, it supports what we have found with all the efforts to try to therapeutically raise HDL levels to no avail
Right.
a couple of decades ago. But yeah, in that situation, so first of all, again, I would come back to ApoB, because a lot of the time that so-called high cholesterol is in somebody who's not had their ApoB measured. So I want to know what that is. So if we're talking about an example where you have an isolated elevated ApoB and LDL cholesterol and everything else looks good, that's a bit of a different story. But I mean, it just sort of depends on how hard you look, whether or not you find something. And for those populations, I'd want to go through their diet with a fine-tooth comb, and you almost inevitably find something. We're going to talk about sleep. We're going to talk about stress, all of the other things that we can optimize as much as possible.
Right.
Just cognizant of time, I do want to touch base on statins before we close off. So now we're talking about a situation where somebody has been deemed to have a statin indicated condition, as the guidelines would say. So that would be, you've met a certain threshold, or you have diabetes, or you have peripheral vascular disease, or established cardiovascular disease, which would be you've had a heart attack or a stroke in the past. Statin therapy, millions of people are on it in North America. There are some camps that are strongly opposed to statins and think that all of the all of the data are overblown and industry biased and all sorts of things. Can we confidently say that statins extend people's lives?
Yeah, definitely. So there's no question. Yeah. So for every, and it's something like, so overall mortality for every 1 millimole, you reduce LDL cholesterol in a high risk patient, the total death of all causes is reduced by about 10%. So another way of looking at it is that for every 10 months you take for a high risk person, right? For every 10 months you take a statin, you get 1 month of life. So it's kind of like a guaranteed investment certificate. So that's on the positive side. So then we did this like calculation for all of London. So if you then take high risk people in London and you treat 10,000 of them, and you're going to prevent something like 1,000 deaths or hospital admissions or like use of the emergency room or all of that. So it just seems overwhelming. But the issue with statins is, like anything, you have to give it. Then why not just put it in the water? Well, because they also, there is the risk, like anything that has good effects, there's always the risk of side effects. So the only thing that's got like no risk of side effects are things that have no effects in the first place, and even placebos have side effects. So then if you're giving statins to low risk people, the risk that the chance that you're actually helping them you're going to help them, but you're going to like need to treat like millions of them to help like one person. And then on top of that, then you have to like then live with the annoying muscle aches and, you know, all of the things that that people are concerned about when they take the statins. So I think the main issue with statins is to make sure that they are targeted, that they're given to the right person. They are definitely revolutionary drugs. There's no industry conspiracy because since 2003, statins have been generic in Canada. So there's no big pharma company promoting statins. They're like generic drugs made in Quebec, you know, and so it's but you know, it's like everything. There's, you know, like there you have to weigh the pluses and the minuses, but on the net, I think there's pluses to statins if given to the right person.
And how do you counsel people on the most common side effects? Because I mean, I almost inevitably, when I go to initiate somebody on a statin, they go, well, you know, my friend had
Yes.
really sore legs, and I don't know if I
Yes.
want to do this.
Yes. So that's so when we kind of look at it objectively, 85 to 90% of people get no side effects. So whether you look in just the observational database or in clinical trials, it's even lower. It's like, you know, like 7% or 5%. We did a study here, which was called an N of 1 study, where we did this with my colleagues from St. Joe's Hospital, Dr. Joy and Dr. Mann, and we blinded people with respect to whether they were getting placebo or statin. So these were people who said that they were for sure the statin always gave them muscle aches, they always felt bad, but then they agreed to do this trial where we said, okay, you're blind. The only person who knows what you're actually getting, whether it's active drug or whether it's just like a placebo, just like an inert pill, is going to be the pharmacist. I don't know what you're getting. You don't know what you're getting, but here's a diary. You record whether you're getting muscle aches or not. And so we had a bunch of patients that did this for a year, and guess what we found? That when they didn't know what they were getting, they were reporting muscle aches just as frequently as when they were taking placebo, as when they were taking the active statin. And then this study was recently repeated in England with a bigger population, and they found the same thing. So, but on the other hand, I believe my patients. So when my patients tell me they're getting muscle aches, and it's usually then, you know, aches in the thigh or aches in the calf or in the shoulder, like, I believe them, you know, and if this is a potential impediment to taking the statin, you know, for sure, you know, we take them seriously. But I tell them that these muscle aches, while annoying, like nobody ever died from them, and you know, so that it's and they're totally reversible. Like once you stop taking the statin, they go away, and you know, we can mitigate them. You know, we can then switch to another statin, or you can take a statin on an alternating day basis, or we can mix in a non-statin drug like ezetimibe that then allows you to take a lower dose of a statin. And there are these different things. What else was I going to say? Yeah. Anyway, this is a large part of my practice is to try to convince patients of the benefits over the risks, and that I mean the risks are real, but I think they are small, and I think that compared to the benefits in the right patient, I think they are.
And is there a potentially a time varying component? So I'm just thinking, a patient I saw on Monday, she comes to me with a history of trying 3 different statins in the past and being intolerant because of symptoms. This was more than 5 years ago. And you know, so far in our relationship, she hasn't agreed to go on them, but I finally convinced her because she's high risk,
right?
And so we're going to start a low dose every other day regimen and see what happens. But you know, is this something that, you know, do you think she's so convinced that it's going to happen again that, you know?
I've seen that where, yeah, so I definitely have patients, and so the prime example is that then so there has been some change in their health. So they're now starting to get shortness of breath, they're starting to get chest pain, or they've reached the age that their father died of a heart attack. and then all of a sudden this becomes more real to them. And so then whatever sort of impediment or, you know, aversion they had to the statin when they were younger, that this it's less, or they don't complain about it at all. So it just is out of the picture all of a sudden. So yeah, I have definitely seen that many times for sure. The other thing I wanted to mention is that there is this kind of like a observation that if you give like CoQ10, ubiquinone, coenzyme Q10, that mitigates the muscle cramps or the muscle aches. And there actually have been a couple of blinded clinical, like randomized clinical trials where that's been done. In one trial, it made no difference, but there was one trial of around 300 people where it did, where the patients, when they took the CoQ10, they seem to be reporting fewer muscle symptoms related to being on the statin. So that's, and then CoQ10, you know, doesn't affect cholesterol metabolism. It's just an out-of-pocket expense. So that's another thing that I you know, I sometimes recommend, or not recommend, but I tell patients that, you know, this, you know, could
Just
be
to
a
try
way
it.
just to try it. Yeah,
Yeah.
it can't hurt.
Now, and one other question that I get is, you know, if you've got a condition that indicates a statin, you know, do I need to be on this for the rest of my life? What do you say to that?
Yeah, so my answer to that is until something better comes along, and there are new treatments. So 5 years ago, like, we didn't have these like injectable treatments now for cholesterol. So we have these ones that are on the market now, and unfortunately, they got rather a limited clinical use because they're still quite expensive. You pretty much need insurance to cover them, but they are like amazing. I mean, I'm sure you've seen patients on them, Andrew. They are like just amazing
You're referring
medications.
to the PCSK9
PCNI
inhibitors,
inhibitors,
Repatha and
right?
Praluent. Yeah.
Product, very, and like virtually no side effects, and just like, you know, sort of 80% reduction in cholesterol. And these are given twice a month, and you know, and patients, so you know, patients adapt to them very well. There's now a newer one that was just approved about 6 weeks ago, 6 to 8 weeks ago, by Health Canada, which is a twice a year injection, which is called Leqvio, Leqvio, and it's an antisense RNA drug. So RNA technology, people think RNA, but you know, like the COVID vaccines are like RNA technology. So, you know, it's just another example of like how technology has given us a new treatment option. So that's the same thing, that like kind of lowers LDL by 60%, just 2 injections per year. Theoretically, you can you know, take statins out of the equation, and it will lower LDL. So it's still very new. I mean, it's in fact, I don't even think you can prescribe it yet in Canada. It just was approved by Health Canada. But in answer to your patient's question, how long do I have to take the statins? Well, there's always new things coming out. You know, 5 years from now, we may be treating this in a totally different way.
And you know, should the PCSK9 inhibitors be more readily available and publicly reimbursed for a broader section of the population?
Yeah, see, I think they should. I think that you see, the error is, I mean, they're expensive to make, I guess. So the drug companies charge a lot for them, and they're trying to make their money back. And sort of, I get that. And so I'm not, but so I think part of the issue is the expense. So I'm always like, if people ever ask me for my opinion, I'm always like trying to say, well, you know, just charge less for them, you know, and just, you know, but so I think that's the first thing. And then I think if there are more options on the market, that maybe there'll be more competition. But in general, yes, I think, and in England, they're doing this very, like, in fact, together with the National Public Health Service in England, there is a large study of the second drug that I mentioned, the RNA, the twice a year injection, where they're making it more widely available, and they're just kind of doing like a real time, you know, real life clinical trial with broader, you know, broader use, younger ages, and just seeing what happens in the real world when you use it. So I think we'll get there. So I personally think, yeah, these are, and the more experience we have with these drugs, I've had patients on them now for like 10 or 11 years. So I think they end up being like, they're very safe over that duration.
Okay, before we let Rob go, Tommy, do you have any cross-examination?
I do. I have a few questions that I think are important for us to touch on, and I don't think they'll take very long to answer.
Okay.
But for people who are listening, and I think they'll be helpful. So we talked about the ability and some possible interventions for reducing a high level of cholesterol. But
Right.
what about when it comes to actual injury to the vascular system? When you talk about lesions that are the precursor to blockages,
Yeah.
is it possible to reverse that damage? And if so, what avenues can people take to do so?
Yeah, that's an awesome question, Tommy. So where we do have direct evidence, like actual imaging studies done with angiography that was like done at the Cleveland Clinic, and what they showed was that if you, and again, we're back to cholesterol, if you can get the LDL cholesterol number down to the critical cutoff was around 1.5 or 1.4, that then when they went back, so they did angiograms. These are all patients with heart disease. They did angiograms of the coronary arteries. They then treated them all down to this, like, what used to be thought of as like quite a low level, but now is like, this like it's kind of standard. And they went back a year later, and they found that the plaques had reversed. There was less plaque in the same spot, like, and it was like in everybody. There was like a thousand people. So that's one way for sure. So we know for sure that it works with cholesterol. Probably will work for other things like inflammation, probably for blood pressure as well. We just don't have that. We just don't have the smoking gun evidence. We don't have the actual photographs that show the plaques reversing. But I believe, any risk factor, if you get on top of it, you can. So these are not permanent lesions. You can actually reverse them.
Well, that's good news. And then I
Yes.
also had a question about non-diagnostic symptoms. Is there any commonality in symptoms that people complain of as a precursor to learning that they have cardiovascular disease? Whether it's like an elevated heart rate or sweating at night or something like that, where if there's this new occurrence of the symptom that you're having at home, you should go and see somebody.
Yeah, so by the time they come to me, they're actually quite advanced. They're actually, as many of them talking about, the classical, kind of central chest pain, radiating the arm and radiating into the jaw, and like, but that's like at the end of the road almost. So you're thinking about something earlier than that. So I think maybe Andrew might be in a better position to answer that from your observations. So what do you?
One of the common jokes amongst general internists is how much we love the referral for fatigue or non-specific set of symptoms. So unfortunately, the answer is no. There really isn't, unless you do have the classic type chest pain, which is far more likely to happen in a man than a woman, unfortunately. So women often have atypical symptoms and chest pain indicative of an actual heart attack or something that severe. So outside of you having symptoms that suggest an underlying acute process, then there honestly isn't anything that really correlates well.
So you're so unhelpful.
Yeah.
I know. Yeah.
So I have one question, and this could be a closing. This could be a closing question if Andrew doesn't have anything else. But I wonder if there's something that you predict is going to be very different about what we understand about cardiovascular disease. So to give you an example, if I were to ask a dentist, what do you think, 10, 20, 50 years down the line in the practice of dentistry, what is something you think is going to be revolutionary or very different than the practice of dentistry right now? And a dentist might say, we will have an alternative to drilling cavities, some sort of alternative treatment that doesn't require us drilling holes in people's teeth. Is there anything like that in heart disease where you think, 10, 20, 50 years down the line, it's going to be completely different than how we understand it right now?
So I can start. I can tell you that there are some people that are working on a vaccine, like the equivalent of a childhood vaccine, that would be given in childhood, and that then it was sort of then what you were kind of alluding to with your kind of global protection from injury, that it would kind of allow the vasculature to withstand future injurious. Now, so I've heard like researchers, like, that's sort of what people are talking about. So these kind of lifelong vaccines, one shot, one and done. Another thing is, there are also more advanced versions of these biologics, but they're treating specific things, like, treating or preventing diabetes or preventing cholesterol problems in the first place or whatever. But there is this thought that it would be possible to have a vaccine that just like we've eliminated smallpox, or like we've eliminated polio, that we would eliminate, or largely eliminate it. I mean, we'll eliminate heart disease as well.
Interesting.
There's been some interesting stuff with the notion of the poly pill. So there have been a number of different randomized trials looking at that. So this is like a single pill that you take that includes a statin, an ACE inhibitor, a diuretic, just maybe some low dose aspirin in there, meant all to be cardioprotective. And those are positive studies. So that's that's interesting. We just don't know who ultimately that should apply to. But I think, like, precision medicine is still in its infancy, and there's going to be a lot to do with that. I mean, Rob, obviously you've been working with genetics and DNA based treatment for a long time now. But I feel like there may be a bit of a renaissance in the next 10 to 20 years as it comes to that, and how we target people specifically for treatments. But
or maybe people will just start taking better care of themselves.
Yes, I would love to think that was true, but I need to keep a job.
Well, and you would think that if that was likely, it would have happened by now, and it does not seem like we're moving in the right trajectory, unfortunately.
Yeah. All right. Well, listen, Rob, I really appreciate your time, and I think this was a really valuable discussion that people will benefit from. So maybe we'll have you back for a part 2 at some point, and pick your brain some more.
Yeah, definitely. Well, thanks both of you, and Tommy and Andrew. I appreciate it. I appreciate the opportunity. So take care.
All right. Bye.
Bye-bye.